Hello, my name is Dr. Laura Periman. I'm a board certified ophthalmologist and I have my own private practice in Seattle, Washington. I'm the founder and director of dry eye services and clinical research at the Perryman Eye Institute in Seattle. And we started our dedicated ocular surface disease center in response to the enormous need amongst our dry eye patients. Everybody's heard about the lacrimal functional unit at this point, right? So, what is the lacrimal functional unit? It is the electrical wiring and the apparati involved in basal tear production. So, that is critically important for maintaining vision, preventing damage to the ocular surface, dealing with potential bacteria, virus, fungal invaders, maintaining a clear visual interface without discomfort. And it's under constant monitoring, neurosensory control, micro adjustments in response to environmental stress. That's essentially what the lacrimal functional unit is tasked with. It has a big job, and a lot of things can impact the lacrimal functional unit. Um, so not only do you have the sensory apparatus in the cornea that we'll talk more about, but you've got the neural signaling and the command fibers to the lacrimal gland, the meibomian glands, and the goblet cells. Those are all under this neurosensory control of the central nervous system. So we used to think that meibomian gland dysfunction was this big separate entity. Well, and it turns out it's a intimately related component to this big, noisy, messy disease state. It is not the sole cause like we used to think. It is part of this cacophony of risk factors that create the situation of dry eye disease. And that can include a myriad of things, such as the surgeries that we do for patients, refractive surgery, cataract surgery, contact lens overwear can damage the lacrimal functional unit by damaging the corneal receptors that sample the quality of the tears. And then, of course, there's autoimmune disease, medications, lifestyle. All of these myriad of factors contribute to the risks and perpetuation of dry eye disease. And what we see clinically is things like a rapid tear breakup time, and that's best observed not with your fluoresce drop with fluorescein and numbing together, but rather with a BioGlow strip or just a little bit of fluorescein impregnated dried strip that you wet with simple sterile saline to highlight the tear film. And now you can make some keen observations. There's also hyperosmolarity is a significant component of dry eye disease, and hyperosmolarity is part and parcel to the disease state and the damage that occurs. And it's even correlated with errors in post-refractive, post-cataract outcomes, hyperosmolarity. So another aspect of it is inflammation. And then finally, the neurosensory abnormalities. That's part of the definition of dry eye. But what does that mean? That means you can have nervous or sensory or neurosensory compromises to the entire tear production homeostasis apparatus. And it starts at the cornea and the lids, goes back to the brain, it's integrated into the brain, and then you have command fibers. So you can see how things like concussive injury or stroke or radiation injury can also contribute to dry eye disease. To me, this is very, very interesting. Hyperosmolarity is one of the things that we can actually measure with our point of care testing, and it's key to identify prior to any type of cataract surgery because of its known impact on IOL calculations and refractive outcomes. This is the excellent work of Alice Epitropoulos. But hyperosmolarity also has some other mischief factors involved with it, and that's hyperkeratinization of the lid margin. You'll see that heaped up epithelium right at the lower lid margin that you just want to scrape away with your spud or your chalazion curette. That is a sign of a whole lot of inflammation and hyperosmolarity going on. The hyperosmolarity also impacts the corneal nerves, also impacts the epithelial cells, contributing to their shriveling and apoptosis. And hyperosmolarity can be the consequence of chronic inflammation, but can also re-trigger the entry point of chronic inflammation. So it becomes an important element to identify. So My background is in molecular immunobiology, so I find this incredibly interesting, and there's a lot of cytokines and factors, and you can get into the weeds of it, or you can, like, broad brushstroke understand where these inflammatory factors come from. And this is a diagram adapted from a review paper that we published in 2020. And essentially, the immune response is twofold. You have the innate immunity, and then you have adaptive immunity. And inflammatory triggers can trigger innate immunity. In a normal, healthy system, you have initiation of inflammation, amplification, recruitment, and damage, but then repair, right? So that repair element back to homeostasis is what gets lost with dry eye disease. It can't return to homeostasis because now we're in the realm of adaptive immunity that's constantly re-triggering innate immunity as well, helping to explain the source of flares. So any type of injury, environmental stress, infectious process, etc., is going to initiate inflammation as before, create T cell recruitment and all those inflammatory cytokines, damage and self-perpetuation, but there's no brakes on the system. That ability to return to homeostasis has been lost. The sensory nerves have a critical role in sampling the quality of the tears and sending a signal back to the brain for, hey, I need more aqueous, or I need more evaporative protection. Hey, my meibomian glands, I need more. Or the goblet cells, geez, there's all these allergens. I need to pump out more mucin so I can catch those like fly paper and flush it downstream with the blinking down the punctum and the nasolacrimal duct. It's fascinating how intimately controlled the tear quality is. And it's important to understand that the initiation part is these corneal nerves and nociceptors. Their job is to sample osmolarity. Hey, it's getting a little salty in here. Lacrimal gland, can you pick up the pace a little bit? That's the type of signaling and crosstalk that continually happens. It reminds me of the rheostat in the wall of the room that you're in, constantly sampling the temperature and sending the signal back to the controlling apparatus to adjust the temperature to maintain that steady state. That's how things are supposed to work, and that's how they do work in a normal eye. But unfortunately, with dry eye disease, you've lost that neurosensory control, and hyperosmolarity can trigger it, and you can get pain from these chronic triggers, and we do see that in our patients. Nociceptive receptors, we're going to start talking about a family of molecules called TRP, transient receptor potential molecules. More on that later, but those also have a role in homeostasis, pain signaling, inflammation, amplification. It's not just the T cells and all their mischief. There's a lot going on with ocular surface inflammation and disease. And then let's not forget about blinking patterns. It's not uncommon for the dry eye clinic to be the first to suspect Parkinson's disease in patients. One of the early hallmarks of the disease is an altered blink pattern. In addition to the flat affect, the soft voice, there's a characteristic change in the blink that results in a compromise in the tear stability and composition that can initiate inflammation. TRP, this is a super family of sensory receptors. So there's all these different types of TRP receptors. The TRPM8 particularly has voltage-gated channels, and this explains why they don't function when there is sodium channel blockers such as proparacaine on the ocular surface. Their job is to sample changes in temperature, like minute changes in temperature from the cooling effect of evaporation of the tears, to pH changes, and make those adjustments accordingly. If you get lemon juice in your eye, that's going to be sensed by a TRP receptor, and then it's going to produce more tears to flush that acid out and return that pH back to physiologic normal. So the TRP is a super family of molecules that you're going to be hearing more about. TRP V1 and A1, those are intimately involved in pain signaling, and it's an active area of research in pain management and some branches of oncology. So we talked about the immunologic aspects of dry eye, that initiation, amplification, recruitment, damage, and self-perpetuation, that loss of homeostasis control. And I think it's an important concept to understand, particularly as our thinking around dry eye disease has evolved. We used to split aqueous or evaporative. It turns out they are on top of each other and they're intimately related to each other. My favorite paper of 2016 was Christophe Baudouin's BJO paper describing the double vicious circle cycle. And to me, this makes significantly more sense in understanding the chronic vicious circle of dry disease and the importance for intervening. You don't need to split aqueous or evaporative because then you forget about the goblet cells. You forget about how inflammation impacts the lacrimal functional unit and drives MGD. They're on top of each other. It's chronic vicious circle activation. So leaning on this concept of how the double vicious circle is a better way of understanding dry eye disease, I think really helps the clinician gain a better roadmap, and it helps the patient understand better what's going on, because all these risk factors are feeding into this double vicious circle, which is essentially you can get on this circle at any point from any one of these risk factors: tear hyperosmolarity, apoptosis, or damage to things like goblet cells, which we know happens with epidemic keratoconjunctivitis, chronic BAK exposure, etc. Inflammation, we talked about inflammation. That's part of this vicious circle diagram. And tear instability, all of those on the outside are driving MGD, and MGD is driving evaporative stress, which is driving tear instability, hyperosmolarity, apoptosis, inflammation, damage to the port goblet cells. So this is a better way of understanding how the vicious circle of inflammation perpetuates dry disease and becomes a way to understand how we pull out different therapeutic targets, which we will talk about in future sections. Hello, my name is Dr. Laura Periman. I'm a board certified ophthalmologist, and I have my own private practice in Seattle, Washington. Well, it starts with taking a good history. Your training that you received in med school still holds. You need to have a good history for the patient. Surgical history, medication history, lifestyle, risk factors. You need to assess those things because it helps to drive your hunt of what the main contributors are. Ask about travel patterns, how much screen time they have, how long have they had it, are they a contact lens wearer, or did they have refractive surgery? And of course, the relevant medical history is very important as well. We've added on even questions such as, did you have a lot of acne in your teen years? Did you have oily scalp, skin, hair, dandruff? Those are additional things that can clue into the nature of what's driving this individual's ocular surface disease. And you have some friends in your pocket for asking the right questions of your patients. And you'll see these standardized, validated questionnaires in different publications and even clinical research. So let's go over a few of them. The SPEED questionnaire, SPEED 2, the OSDI, the Ocular Surface Disease Index, the NEI VFQ25, but also don't forget about VAS, visual analog scores. This is a really neat way to assess the severity for an individual patient. You ask a question, are you experiencing eye dryness? And it's a line that's literally 10 centimeters long. Patient takes a pen, marks the spot, you measure it. Oh, 67. Yeah, that's pretty dry, right? And you can use it as a way to monitor response to therapy. So you'll see VAS scores in more and more dry disease phase 2, phase 3 treatment or clinical trials. So you're going to see these questionnaires. So you have help in asking the right questionnaires, and then get a really good comprehensive intake form that you can do in the lobby while the patients are waiting. You can QR code these. It can become a CSV huntable database within your clinic of symptoms. So they're effective ways to ask the right question. So now that your index of suspicion is elevated, the next question is, what are the key recommended tests for diagnosing dry disease effectively? Well, it turns out that the symptoms of dry disease can overlap with other conditions, such as environmental allergies, dust mite allergies. These are important things to discern in your patients so that you don't reach for an antibiotic when that's not what they need. What they need is a topical mast cell stabilizer antihistamine. So I think these are important points of distinction, and there's some clinical in the lane tricks that you can do to help you figure out, is this allergy or is this dry eye? Just keep a bottle of OTC anti-allergy medications and put a drop in one eye. You'll have your answer in 3 minutes. If that eye feels significantly better than the other, then you know that there's an allergic component going on in this patient. The AAO, American Academy of Ophthalmology Preferred Practice Patterns, does suggest a multi-test approach, and here's the nerdy reason why. The tests in our bevy currently they have problems with sensitivity and specificity. A prime example of this is the Schirmer's test. It has poor sensitivity and specificity until late in the disease state. By the time you see significant drops in Schirmer scores, anesthetized or unanesthetized, things are pretty dry. And you don't want to let your patient get to that point if at all possible. But before that, it can be all over the place. You can get reflex tearing if it's an unanesthetized Schirmer score. So Schirmer scores is the best example of this. Some tighter sensitivity specificity tests include things like osmolarity testing, lactoferrin, IgG testing. Those are not commonly used point of care tests at present, but I'm hoping that that will grow as we move forward so we can be even smarter about how we track down dry disease and treat it logically and effectively. And then hats off to the American Society of Cataract and Refractive Surgery and their excellent ocular surface disease identification and treatment algorithm preoperatively. They did employ hyperosmolarity testing as part of the workup. Also, MMP9, that's a nonspecific marker of inflammation. We talked about all those T cells and the chronic vicious circle of inflammation, initiation, amplification, recruitment, damage, and cell perpetuation. Well, it turns out MMP9 is intimately linked in all those processes. It's nonspecific, but when it's elevated, you know that there's significant ocular surface inflammation going on. So tear osmolarity and MMP9, those are both positive in over half of all comers for cataract surgery, and either one can be abnormal in about 80% of all comers preoperatively. So it's a high yield, rapid point of care test for screening and identifying these patients preoperatively. Slow down, treat the surface, get that dry disease more stabilized, then repeat your measurements. I think you'll be surprised to see what you've been missing. So by combining osmolarity and MMP9, we have a little bit more of a safety net, and it still works with our busy clinic flows, and it can help direct the need for other treatments. The other thing that I love about the ASCRS algorithm is it's reminding us to look at the lids. Look, lift, push, pull. This is a simple, rapid thing that you do in the exam lane, looking for things like laxity, lid malpositions, significant meibomian gland dysfunction, significant conjunctival chalasis, ptosis of the levator, brow ptosis, ectropion, entropion, lid laxity. These are important considerations in the perioperative patient because your lids are responsible for blinking and spreading, protecting ocular surface, spreading the tear film, maintaining stable vision. So I love this simple testing approach and the reminder to do a physical exam. Look at the lids, lift the lids, push on the glands, pull on the lids, looking for all of these other contributing elements. So let's say you're suspicious about different comorbidities in your dry disease patient. How does that, plus the pathophysiology of dry disease that we've talked about, how does that inform which tests you do? Let's talk a little bit about this. So by this review and understanding of the underlying pathophysiology and disease mechanisms, it helps us look for comorbidities. Prime example, easy example, is autoimmune disease such as Sjogren's, primary or secondary, secondary Sjogren's is heavily associated with rheumatoid arthritis. Those require blood testing. That requires looking at the blood, ask about family history, look for that characteristic staining pattern. If you see heavy lissamine green staining on the conjunctiva and the interpalpebral fissure, your index of suspicion for underlying autoimmune disease should go up. And when you diagnose it and identify it, it helps to guide treatment options, which often involves systemic anti-inflammatory strategies, such as adrenocorticotropin hormone analogs. There's different coordinating with your rheumatologist, etc. Things like rosacea uh, are a significant contributor, a common contributor to identify to ocular surface disease, and we have wonderful effective treatments for it. So look at the skin, look for the presence of telangiectasias on the lid margin, lid thickening, look for collarettes. Identifying Demodex blepharitis is an easy button now that we have Lotilon or 0.25%. Pick the low-hanging fruit. Look for these other contributing factors, identify them, and treat them because it can help guide your treatment recommendations. Dry disease diagnostics, thankfully, are growing. Back when I did my training, we had a Schirmer strip. That was about it. So I'm thankful for these different strategies. Definitely keep your old friends. Keep your Schirmer strips, especially for late stage disease. Uh, Use the tear meniscus height. Like you can measure it with OCT if you have enough staffing and enough equipment, and that can be a helpful thing to track as well. I just grade it just generally in the lane, low, medium, or elevated, or low, normal, or elevated is how I grade the tear meniscus height. Fluorescein tear breakup time, non-specific, but an important thing to look for. Put your fluorescein strip in the eye and count, blink, blink, stare, and then count looking in seconds in your head while you're looking for that early black pattern to appear in the tear distribution. The non-invasive tear breakup time tests are helpful to have, but nothing replaces your exam. The osmolarity standard of care, that's like a blood pressure cuff on a primary care patient. I need to know the lacrimal functional unit is functioning in real time. So osmolarity is part and parcel to our workup. Advanced testing technologies such as lactoferrin, immunoglobulin, that can help you discern significant allergic component of disease and how lactoferrin is another metric of the health of the lacrimal gland. Those are not common point of care tests, but they're some clinics have it and they're nice to have. Tear drainage, we mark on every single patient what we call FDDT, fluorescein dye disappearance time. And in some people, it's rapid. So I know they've got good tear inflow. In some patients, it doesn't clear. So they've got poor outflow or poor inflow of the tears. So those are little tip-offs as well. Definitely do your staining after you've put the fluorescein on the eye, not with fluoresce. Again, it needs to be just the fluorescein impregnated strip. Wait at least 60 seconds. That fluorescein needs time to get to those little defects in the epithelial cell tight junctions of the cornea and the conjunctiva. So don't forget that it needs a little time to set up, but you can be doing the rest of your exam while you're waiting for that fluorescein to get in there to highlight the areas of damage. And you can use that to track response to therapy. Ocular and conjunctival redness, really bothersome to our patients, and it's pretty nonspecific. A lot of things can cause redness. So I find it helpful in clinical research studies, and it's just a soft, subjective, qualitative sign clinically in our clinic, but we do use advanced testing in clinical research. Mammography, it's such a great, simple, easy, rapid point-of-care test, non-invasive, that can really tell you a lot about the structure of the meibomian glands. Here's where people get into a tizzy. They think when they see significant meibomian gland dropout that they're losing the glands, and that might be true, but it's a slow boat. This process happens very, very slowly, and you can often see improvement in the appearance, length, width, terminal ductual ending on my mammography with interventions of therapy. So it's a slow thing, but it's an important image to convey to your patients and can be easily done at point of care in your perioperative or preoperative patients. Hello, my name is Dr. Laura Periman. I'm a board certified ophthalmologist and I have my own private practice in Seattle, Washington. So current treatment options are there's a variety of constructs and a variety of treatment algorithms. The cliff notes of all of those is identify and treat it. And the more severe the situation is, the more treatment you need to put on in order to get it under control. But underpinning all of that is doing your best to figure out the driving sources, the key contribution of elements to the dry eye disease. What are the comorbidities? What's really driving this? So the vicious circle of inflammation, aqueous deficiency, MGD, they're on top of each other. They're not bifurcating. This is a biologic system, and these are related to each other based on the loss of homeostasis, driving inflammation, tissue damage, desiccating stress. Desiccating stress can be from a variety of things, such as medications, lifestyle, and environment, and neural stimulation approaches can help us to augment that what should be a normal and seamless response to environmental stress in a way that enhances that normal protective mechanism. That's where neural stimulation comes in. Tear supplementation, obviously, that's a mainstay. Make sure it's a quality one. And tear conservation, there's even some innovations here. Not just a hard plug, silicone plug that can rub the conjunctival surface raw and create other symptoms, but now we have intracanalicular hyaluronic acid gel, which is a better mousetrap. It conforms to the space in a way that is not as irritating as the sharp edges of a foreign body, such as a intracanalicular hard plug or a silicone plug. So that's become my preferred mode of tear conservation by a long shot. Perfluorohexyloctane is brilliant at addressing evaporative stress. Not only does it sit on top of the tear film, but it helps to reduce friction. And friction is a significant component in many of our ocular surface disease patients. SLK, conjunctival chalasis, ocular fatigue, decreased tear production, all of these things can incite friction. Tissue damage, your mainstay, your good old friend, steroids used strategically and therapeutically, and monitoring for side effects, of course. We're all still using steroids. Immunomodulators, cyclosporin, lifitegrast. There's many ways of delivering cyclosporin. There's many different delivery systems, thankfully now, so you can help your patient with the tolerability profiles of that molecule, which is so helpful. Lifitegrast, fantastic for addressing that T-cell activation problem with ocular surface disease. So it becomes my drug of choice in patients with a significant allergic comorbidity to their ocular surface disease. Biologics, love autologous serum. We love PRP, platelet-rich plasma, as a nutritive eye drop. You can make it in office under a sterile flow hood conditions. Amniotic membranes, fantastic for a drug-free approach. Don't forget about this inflammation part. You have to eat nutritiously. Things like omegas, things like high antioxidant supplements, the ideal combination of omegas, HLA and GLA, and antioxidants are helpful. Steroids are your friend. Immunomodulators are your friend. Melanocortin analogs in preclinical development, very interesting approach. And then RASP inhibitors. Reproxalap is very exciting as a very high upstream way to approach inflammation. So I think there's still potential there. And then the treatment options, thankfully, have expanded, right? Level 1 disease, get the allergy under control, not through an oral pill that dries you out, topically, right? Lubrication, warm compresses, lid hygiene, those are base level stuff. Don't forget to talk about nutrition. Level 2, all of that, plus identify Demodex, tear conservation strategies, as long as there's not a significant allergy season for that patient. You don't want to trap the allergen load on the ocular surface and drive meibomian gland dysfunction. So there's a time and a rationale and a point for tear conservation strategies. In-office expression of the meibomian glands, whether it's an automated system, a manual system, or a heat and manually expressive system, treating the meibomian glands, getting that quality better so you can enhance the stability of the tear film. Think about things like perfluorohexyloctane to stabilize the tear film. Loteprednol, your good old friend, gentle corticosteroid ester, great safety profile in most patients. Cyclosporin and all the different ways that we can deliver that good old friend molecule to the ocular surface. Lifitegrast, so unique in its ability to be specific in managing ocular surface disease in many of these patients. Oral antibiotics, I really don't prescribe, but it's on the list of dry disease approaches. IPL therapy is a level 2 intervention. Neural stimulation, we reach for those all the time. The veronical nasal spray, the extranasal eye tear device, topical secretagogues, those are available in countries outside of the US in some of them. Another great strategy, but we need more tools. By the time you get to be a level 3, it's all those treatments, scleral lenses, autologous or amniotic membranes, et cetera. And then level 4 often requires surgical approaches. This is a new category, a new approach by stimulating key receptors on the corneal nerves in order to jumpstart a complete physiologic basal tear. So just a quick review of the TRP superfamily. We're going to zero in on TRPM8. This is responsible for detecting micro changes in the temperature of the tear film and sending signals to the brain, hey, I need more tears, right? So we're going to stimulate that guy to enhance basal tear production. TRPM8 is responsible for basal tears. You have reflexive tears and you have basal tears that are just constitutively being monitored and adjusted and expressed and stimulated. It's a voltage gated channel, so you're not going to be able to stimulate TRPM8 if you have anesthetic drops on board, right? And you'll see some of this borne out in the FDA clinical trials. I still use the intranasal spray, Varenicline. Not everybody can tolerate it. The iTear device is popular. It's found around the world, and it's another way of stimulating a physiologically complete tear. This neuromodulation is like attaching to the actual neurosensory receptor on the corneal surface, which makes it so unique and fun and interesting. So I find neural stimulation in general, as the broad category, to be an important adjunct to everything that we do in our ocular surface disease specialty center. And I think it's going to become more and more commonplace amongst our colleagues as they address dry eye disease. I think we can all agree we need more tools. We need specific tools. We need to be able to like hone in more precisely on what the problem is. Dry disease is long term. It has exacerbations and remissions. It's not a straight line. It's full of bumps in the road, exacerbations and remissions. My goal is to get those exacerbations fewer, further between, and less severe. I want to restore as much physiological normality on the ocular surface as I possibly can. And that's where things like tapping into basal healthy systems that are involved in homeostasis, such as the neuromodulation with the TRPM8 approach, I think are going to be really interesting in clinical practice as we move forward. So let's talk a little bit about some of these treatment options. Back to that favorite paper of mine of 2016, the BJO Christophe Baudouin's double vicious circle cycle analogy. This is a great framework for understanding our current therapeutic options and where the new things are. And it also helps to hammer home this concept of there's a lot going on in this busy disease state. It's not straightforward at all. And all of these things are intimately related to each other. So what you see in red on this diagram, or orange, if you will, is things that are in development. So let's talk about just a few of these things. Starting on the right, bacteriophage therapy. Bacteria flora of the eyelids is abnormal in dry disease patients and even more abnormal in Sjogren's disease patients. We want to return to normal, and bacteriophage therapy could be the way to help establish that. Excited for that science, probably 5 to 10 years out from clinical practice. Allergies are a significant driver of a lot of this, and we need ways to prevent the development of them or prevent the development of new ones, as well as get current allergies under better control, back under more normal neural regulation. Let's talk about the nerve stimulation. We have 2 that are approved and 1 hopefully on the way. The vibrational external device, the intranasal chemical device, and then this novel neuromodulatory approach by stimulating TRPM8 molecules with a culture monitor. Small molecule mRNA approaches. Tirvinazarian is an exciting approach to wound healing as well. Reproxalap, I still think has great potential as a very far upstream way of mitigating inflammation. And then more novel approaches at MGD, the AZR molecule, which is selenium disulfide, to address hyperkeratinization at the lid margin and within the meibomian gland terminal ductules in order to relieve obstruction. So future trends, I think we're going to see more emphasis on mechanism of action, targeted specific approaches at wound healing. such as collagen mimetic peptides to restore the corneal epithelial cell tight junction fence. That's your first defense, tear production and the integrity of those epithelial cell tight junctions. Turns out we might be able to do that with some of these collagen mimetic peptides to restore the quality of the fence, keep the bad guys out and the good guys in. The other approaches include TRPV1 antagonists, really promising for pain. Pain is a significant component for many of our ocular surface disease patients. We need more tools in addition to everything else that we've talked about. I am Dry Eye Master. We can carry on the conversation and stop me in the hallway next time you see me at a conference and let's nerd out about dry eye a little bit. Look forward to carrying on the conversation in the near future.